Assalamu alaikum, good morning, or the good evening, where there the situation. It's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. Let's start our topic. Topic is aqueduct stenosis, and I want to present one case for the analogy so we can understand and we can understand what we are doing here. Actually, there's a 14-year-old adolescent boy present with the long history of intermittent syncopal episode, and he was initially investigated at the age of the 10 by a neurologist with normal cranial imaging and the normal electroencephalogram and the normal physiological examination. Similar episode recurred at the age of the at the age of the 14, and will although his neurological examination remained normal and the MRI was performed by as a part of the further investigation and was significant different from the prior CT scan. So here actually how I want to describe the imaging study of my patient. Actually, the MRI demonstrate ventriculomegaly at the level of the lateral ventricles and some transependymal edema. And there is also a apparent mass in the posterior part of the third ventricle and tegmentum of the brainstem. And what advice should I give to the patient in the terms of the management? Management strategy for this patient can be divided into the observational and interventional strategy. And given the relatively minor history and the lack of the clear relationship between the lesion and the symptoms, some may argue that the patient should be followed closely. However, the change in lesion and the ventricles from the scan 5 years previously and transependymal cerebrospinal fluid on MRI all argue for the treatment for the hydrocephalus. And what would be the basis for the intervention in this patient? Actually, the basis for intervention is the transependymal migration of CSF seen in the MRI and the clear progressive dilation of the ventricle over time, both of which suggest increased hydrocephalus and the probable growth of the mass over the time interval between the two imaging studies. And I want to describe here the surgical intervention for the management of the patient here. The patient could receive CSF diversion by means of the ventriculoperitoneal VP shunt, and the CSF diversion could also be performed by the external ventriculostomy tube, and consideration would be the made for the biopsy of the lesion at the time of the ventriculostomy tube, given the apparent location of the lesion in the posterior and ventricle, and it is not very likely that this lesion will progress, and this consideration for the resection of the lesion would not be necessary due to the absent progressive growth or favorable histology on biopsy. As you know, to describe the risk associated with the above procedure, like the ventriculostomy patient, risk of late or early failure, fornix injuries, and the intracerebral hematoma, hypothalamic injury, basilar aneurysm, or arterial injury, and the uncontrolled bleeding are also there. So are there any specific technical consideration for this procedure? Yeah, technical consideration revolves specifically around the preferred option of ventriculostomy with lesional biopsy, and it would be the essential that the ventriculostomy be performed first to make sure that the procedure was not aborted due to the bleeding from the biopsy, and to perform the ventriculostomy and biopsy a flexible endoscope would be needed. An alternative using a rigid scope consideration must be given to the placement of a single or slightly more anterior burr hole or two burr holes to allow an appropriate trajectory to both the anterior third ventricle and ventriculostomy site and the posterior third ventricle for the biopsy. So, what are the long-term pathogenesis for this patient? Actually, expectation for the long-term control of the hydrocephalus in this patient are good, and approximately 80% is achieved. So typically, tegmental posterior third ventricle lesion of this type are being and slowly growing and are cause no further problem apart for the hydrocephalus. If biopsy was performed, this may further define prognosis. So what could be the management strategy for my patient here? Actually, definitely, as I mentioned, ventriculostomy with or without biopsy should be the best option, followed by the serial imaging observation of the mass lesion. It is very important. And aqueduct stenosis, it is a term definitely we can see on the radiology, but definitely it need a little more explanation, which I want to explain in front of you like this. There is for what are the etiologies for example, aqueductal stenosis. Actually, the common cause of the fetal hydrocephalus may be congenital or acquired, benign or neoplastic. So, adequate lumen normally decrease in size and beginning in the second month of the fetal life and continue until the birth. So, congenital or acquired, benign or neoplastic, it depends. But the commonly aqueductal stenosis causes the fetal hydrocephalus. And aqueductal lumen normally decrease in size beginning in the second month of the fetal life, and it will continue until the birth. So the normal mean cross-sectional area of the aqueduct is 0.5 millimeter, which is ranges 0.2 to 1.8 millimeter, and narrowing caused by the growth pressure upon aqueduct from the adjacent mesencephalic structure. So aqueductal stenosis, pathological obstruction CSF flow in the fourth ventricle, so is a basilar foramen, and the CSF production in the choroid plexus continue, and the lateral and the third ventricle fluid pressure increase, and it causes the ventriculomegaly, and then ventricle expand and express adjacent parenchyma, stretching of the corpus callosum, and may rupture or open ependymal cell junction and transependymal CSF flow. Here I want to mention more, because the aqueductal web, which is the subject of the aqueduct stenosis, actually the thin membrane of the brain tissue within the distal aqueduct restricts CSF flow into the fourth ventricle. Yani aqueductal stenosis or the aqueductal web, actually this is a thin membrane of the brain tissue within the distal aqueduct and restrict CSF flow in the fourth ventricle. And aqueductal fork, sometimes aqueductal fork, it is a branching of the aqueduct into the dorsal and the ventral channels, and other cause such as the genetics. So aqueductal fork, aqueductal web, and definitely aqueductal stenosis, these all three they are causing a significant hindrance to flow of the CSF, and then definitely there is an aqueductal and a CSF restriction, a flow restriction, and cause the ventriculomegaly and the dilatation of the ventricles and so on. Genetic, actually, cell adhesion molecule such as an L1, which is the cell adhesion molecule L1, and gene recognized cause of the human hydrocephalus, because the codes of the neuronal cell adhesion molecule, transmembrane glycoprotein in the immunoglobulin and superfamily of the cell adhesion molecule, gene located in the X chromosome, and the cell adhesion molecule expression is essential during the normal embryonic development of the nervous system, and the mutation in the cell adhesion molecule L1 gene responsible for four related disorder: X-linked hydrocephalus, HSAS, MASA, X-linked complicated spastic paraplegia type 1, and X-linked agenesis of the corpus callosum. So these are the gene related issues. I just want to mention these names because at least you should and we should know, and definitely the repetition will memorize us. And now collectively crash syndrome, you know, the callosal hypoplasia, mental retardation, abduction and abducted thumbs, spastic paraplegia, and X-linked hydrocephalus. So these are called the crash syndrome. It's also a genetic disorder, and in this crash syndrome, CRASH, actually C for callosal hypoplasia, and R for the mental retardation, and A for the adducted thumb, and S for the spastic paraplegia, and definitely H for the X-linked hydrocephalus. And actually the site of mutation within the L1 protein correlate with disease severity. So the associated abnormalities such as the crash syndrome, absence, diminution of the corticospinal tract, and thalamic fusion, and collicular fusion, absence of the septum pellucidum, corpus callosum dysgenesis, thin cerebral mental, malformation of the cortical development, hypoplastic white matter, and aqueductal fork, you understand, because this is considering the associated anomaly and the fusion of the cortigeminal bodies and the cranial nerve 3 nuclei and tactile molding. This is called the beaking, and that will cause the hydrocephalus here. So I want to discuss here a little bit about the differential diagnosis. You know, congenital aqueductal stenosis, no fullness of tectum will be seen, no alteration in the signal intensity of the tectum or any enhancement will be seen. So the brainstem encephalitis and the clinical presentation will be acute. Patient are febrile, and follow-up imaging in 2 to 3 months will usually demonstrate interval resolution. This is the congenital aqueductal stenosis, in that the no fullness of the tectum you can see, and the no alteration in the signal intensity of the tectum or any enhancement will be seen. So the brainstem encephalitis and this encephalitis, this is the clinical presentation with the acute patient with the febrile, and follow-up imaging 2 to 3 months usually demonstrate interval resolution. Brainstem tuberculosis, actually the solitary enhancing lesion in the more usual presenting feature of the brainstem tuberculosis, and however this is the focal pontine glioma cannot be entirely excluded. So based on the clinical presentation, a clinical trial with anti-tuberculous regime can be attempted, and following imaging will be demonstrate resolution of the lesion in case of the brainstem tuberculosis. In more equivocal cases, a biopsy can be attempted. So hemangioblastoma cysts with the mural enhancing nodule will be seen, and more often seen in adults, are associated with the von Hippel-Lindh disease. Simultaneously, we want to know that the skull and the brain and role of the aqueductal stenosis here. So a helpful clue for the less common diagnosis, such as cause of the congenital hydrocephalus may be due to the web or adhesion, often post-inflammatory or post-intraventricular hemorrhage, and we have to assess the tectum carefully on axial T2 or the flare and settle enhancing and tactile glioma, and the intracranial hypertension and download displacement of the midbrain, and the loss of perimesencephalic cistern, and the midbrain assume folded appearance of a downward displacement is severe. So the primary glial neoplasma, such as the multiple histologies, can affect here the midbrain, and the rest of the brainstem imaging varies with the tumor histology. And the tactile glioma, the typically confined to tectum, non-enhancing present with the chronic hydrocephalus. So generally better prognosis than other brainstem tumor associated with neurofibromatosis type 1. So here the primary glioma neoplasm must be considered. Tectal glioma definitely typically is confined to the tectum and non-enhancing presenting with the chronic hydrocephalus, but generally better prognosis is then with the other brainstem tumors associated with the neurofibromatosis type 1. Another disease I want to present here, like the Wernicke's encephalopathy, is a thymine deficiency most commonly seen in alcoholic, and also malnutrition, malabsorption in HIV and AIDS, and the classical triad like ataxia, encephalopathy, and the oculomotor dysfunction. So the symmetrical T2 S1 variable involve periaqueductal gray matter, dorsomedial thalami, and mammillary bodies, and decreased diffusion, post-gadolinium enhancement variably present. So the mitochondria cytopathy typically affect deep gray nuclei of the cerebrum or the deep matter structure of the brainstem in symmetrical fashion, which is the decrease on the diffusion weighted image and the increase on the T2 weighted image, and typically present with the acute flare of the disease, and increased lactate peak is seen on the MR spectroscopy. Brain malformation also play a role here, and the key points are that extrinsic aqueductal stenosis may be considered to focal mass lesion in close proximity to the Sylvian aqueduct and comprise the lumen, and tectal glioma are the low-grade lesions that appear T2 hyper intense, have little to no contrast enhancement or any circumvent to narrowed Sylvian aqueduct. So the tectal glioma may be the subtle and occasionally difficult to identify if a severe supratentorial ventriculomegaly compression and displays the mesencephalic or brainstem, and the lesion may become more apparent after adequate decompression of the supratentorial system, either by ventriculoperitoneal shunting or third ventriculostomy. Vein of Galen aneurysm malformation are congenital midline vascular malformation in which the arterialized and dilated vein of the Galen exert a mass and effect on the tectal plate and the Sylvian aqueduct. And here I want to tell you one more thing, because the vein of Galen aneurysmal or malformation are easily identified on the transfontanelier ultrasound by their hypoechogenic aneurysmal sac, and the matching turbulent follow on the color-coded Doppler sonography. And this vein of Galen aneurysmal malformation are also easily identified by the flow-related signal void or the most MRI sequence, as well as on the various MR angiography sequence. And in vein of Galen aneurysmal malformation, the supratentorial ventriculomegaly is also secondary to the arteriovenous shunting, in which the arterialization of the venous system impair the resorption of the cerebral fluid in the venous system. And the disorder for the cranial volume and the shape, the congenital hydrocephalus caused by the aqueductal stenosis is severe and does not respond to the medical therapy directed at decreasing the volume of CSF, and progresses to a stage that harms the brain, and diversion of the CSF from the ventricular system to an extracranial site is the only effective method of management. So VP shunt is the procedure of choice for the newborn and the small infant with aqueductal stenosis, and it is easier to revise and it is better tolerated when the ventriculoperitoneal shunt. Mechanical obstruction infection are the most common complication of the shunt placement in infancy, and the relief of the hydrocephalus increases the potential for the normal development even when the cerebral mantle appear very thin preoperatively, but does not necessarily result in a normal child. The growth of the intelligence is often uneven, but better development of the verbal skill than for the non-verbal skills, and associated anomalies may cause motor deficit and seizures. So hydrocephalus, the neuropathy, the hydrocephalus correspond to an excessive accumulation of the cerebrospinal fluid within the CNS, especially with the ventricles and the ventriculomegaly, is the condition of the enlarged cerebral ventricles, and the general consensus for the classification is based on the location of the obstruct to the follow of the CSF, and the etiology for the inciting condition and the chronicity or the rapidity of the onset and the age of the patient are experimental animal. Hydrocephalus is one of the commonest CNS abnormality, and it is a complex disorder encompassing a variety of the clinico-pathological condition, and it occurs in isolation or as one feature of malformation and complex, either restricted to the brain and involving several organs and the skeleton in the developing brain. The increase in the CSF pressure causes ependymal tearing and the denudation with protrusion of the underlying periventricular subependymal neurophil, formation of the ependymal pseudoroster into the subventricular zone, and the gliosis. So previously gliosis begins to develop in the subventricular zone and indicating chronicity, and the glial nodules can bulge. So forming so-called granular epidermitis in the developing brain. This region may induce a loss of germinal cell in the ventricular or subventricular zone. Here, actually, the obstructed ultrasound in the hydrocephalus is a general term used to describe a head with the cerebral ventricles are dilated, and many causes are possible, include spina bifida, stenosis of the aqueduct of Sylvius, normal pressure hydrocephalus, agenesis of corpus callosum, fetal toxoplasmosis, other infection, rubella, cytomegalovirus, herpes simplex infection, and other serious development formation of the brain in some cases, in particular those caused by the aqueductal stenosis, and the head can be marked enlarged and lateral, and the third ventricle may be very, very dilated with the marked thinning of the cerebral cortex. And with atraumatic delivery and the appropriate neurosurgical treatment, more than half of the infant with aqueductal stenosis survive, but about the 75% of the survivor have moderate to the severe developmental delay. So the degree of the hydrocephalus and thickness of the remaining cerebral cortex are weak predictor of the neurological outcome. So the appearance of the choroid plexus can assist in the diagnosis for the less obvious hydrocephalus. With hydrocephalus or choroid plexus, which usually fills the portion of the lateral ventricle side to side and appears compressed and the dangle. So the accepted upper limit for the transverse diameter of the lateral ventricle at the atrium is 10 mm, while the ventricle major between 10 to 12 mm. The chance of the normal neurological outcome in 96% and 86% with the measure between the 12 and 15 mm. So whenever any degree of hydrocephalus is seen, careful search for the other malformation is essential, because there the presence is strongly influence and progress and prognosis or prognosis. So the agenesis of the corpus callosum should be considered when modest ventricular dilatation is primarily confined to the posterior horn, although fetus with the spina bifida usually have dilatation of the lateral ventricle, and the head size is usually not increased. And the unilateral cystic lesion adjacent to the cerebral cortex, most likely present an aragonite cyst, and these generally are associated with the good prognosis but can reach considerable size and can cause symptoms such as the seizures or hydrocephalus. And porencephalic cysts are the unilateral cyst lesion in the brain that have a much worse outcome, and this arise from the intracerebral infarct or the hemorrhage with the subsequent liquefaction of the brain tissue or clot, and the resultant cystic cavity within the brain parenchyma may be communication with the subarachnoid space or the cerebral ventricle. So this is the actually some detail regarding this topic. I try to present in front of you. It's the aqueductal. Definitely, it's not fulfill all kind of thirst which is required to answer, but I try to explain in front of you in some humble manner. I hope you will like it. If you like it, please subscribe and share it. Thank you so much. See you in another topic.